Hello, you are most welcome, ladies and gentlemen, to Real Impartation Moment on Tuesday Night Anatomy with Daniel Open. Now, today's section is going to be a part 2 of the orientation to anatomy or the introduction bits, to anatomy that we've already done. So kindly get the video link and watch it if you've not, watched it already. Okay. Now for today, it's going to be a continuation of where we stopped at the last time, and of course also incorporate certain things which are relevant, as far as what we did the last time is concerned. So to begin with, there's one thing that I told you that anatomy, there are 3 main areas that we study, and they were the gross anatomy, that's the macroscopic anatomy, where of course we said those things, they are large enough to be seen with our unaided eye. We also talked about microscopic anatomy, that there are some structures, they are also morphological, they are also having shape and structure, what have you, but we fail to see them with our naked eye. And that is why we need the microscope to help us. Yes, we talked about histology, studying tissues, we talked about cytology, studying cells of the body. Then there was another thing which was developmental anatomy, explaining the basis for certain things that we see at a gross level. And that was the developmental anatomy, where we talked mainly of embryology, talking about of course the prenatal period and the postnatal development. They are those things that we looked at. But there was one thing that I want to tell you, put emphasis on. I told you something that if you look at the gross anatomy, with the macroscopic anatomy, which sometimes I told you that we use the cadaver, the dead body, human dead body, for these kind of studies. I told you that we have that of course, we can study it based on the regional approach. So for instance, if it's my head and neck, I told you that one. If it is of course my thorax, I told you that one. For instance, if it is my thorax, my abdomen, I told you about the pelvis, of course the perineum, the limbs. Now for instance, if you look at my abdomen, this is the area. So if I'm studying this area, that is regional approach to studying anatomy. Now there are some important organs over here, mainly organs of the digestive system. So if I want to study this area again, then I can study the systemic approach as well. I can study the digestive system. Yes, I will still be in this area. Now apart from that, there's one important thing that I want you to know, and that is what we call surface anatomy. For instance, that one is also part of what we call gross anatomy. Now if you want to become a very good doctor, if you want to become a very good clinician, if you want to become a very good, of course, nurse, midwife, and what have you, then sound understanding of what we call surface anatomy becomes very important. Now what we mean by this? Now what we mean is that there are some areas of the body that of course you can of course relate the organs that are deep to the skin over here, to make certain diagnosis. So for instance, someone comes to you with an area which is protruded in the right upper quadrant over here. For instance, if I divide this abdominal region, which for the belly button over here becomes my landmark, and I divide it going through the midline this way, and of course taking a transverse section also through this umbilical region, then what is happening is that I am able to get 4 quadrants. Now this area becomes my right upper quadrant, this area becomes my left upper quadrant, this of course becomes my right lower quadrant, and of course over here it becomes my left lower quadrant. Now what can I do? I can feel the elevated organ over here. For instance, mainly I can say that no, if this area is protruded, then it's likely the liver, which is has become enlarged so much, hepatomegaly. So I can feel it, and feeling it over here, one technique of surface anatomy, that is what we call palpation. Palpate. Sometimes too, there could be some sounds which can be produced when of course I strike this area, so I can listen to the sound that will resonate from this area as I tap over here, and that is what we call percussion. That is also an aspect of what we call surface anatomy. Not only that, if I don't want to tap to listen, if I don't want to feel it to see how it is, I can simply listen to the sound that will emanate from some of these organs, and that is what we call percussion. So for instance, I can use the stethoscope to listen to some heart valve sounds, okay, some sounds that may be emanating from certain areas, and that is one important aspect of cervix anatomy. So please, I want you to know that we also have, as part of the gross anatomy, then sound understanding, okay, of these techniques in cervix anatomy will help you to become a very good health professional. So what have I mentioned so far? Just feeling that is what we call palpation, okay, tapping and listen to the sound that will emanate, that will resonate, okay, that is what we call percussion. And then of course we also have what we call the auscultation. Just listen to, for instance, the heart valve sounds, okay, that is auscultation. Then last but not least, which is also part of cervix anatomy, sometimes someone will come to you, and by just merely observing the person, for instance, you can check, are you anemic or what? What are you seeing at the person? So just by mere visual inspection is a technique which is relevant in what we call cervix anatomy. So that's what I want you to know for now. Now, having looked at cervix anatomy, which is also an important thing which you have to know, okay, then the next thing that I want you to know is one movement which I failed to tell you the last time, and that movement is what we call supination and pronation. Supination and pronation. Now, if you look at this skeleton that I have over here, this articulated skeleton, what I see is that this is the upper limb. Now, in the upper limb, I see there's a forearm, and of course, this is the hand, okay, of course, showing you the bones over there. If I turn it so that there's the dorsal aspect, the dorsum, okay, faces downwards, then that is what we call pronation. So for instance, as you can see over here, my palm faces downwards. So once my palm is facing downwards, this is what we call pronated, forearm, pronated forearm. Now, if I do the opposite, so that this time around, the ventral aspect of my hand, where is the palm, faces upwards, then this one becomes supination, supination. Now, how do I remember these things? The same way, if you go to the hospital, usually the patients who are in the hospital, normal cases, they lie supine, so that the dorsal aspect of their body, their back, okay, is on the bed, okay. That is what you call, supination. So in the hospital, patients usually lie supine, unless of course if it's a special case where of course they have to raise the back a bit, and that's what you call, usually call a Fowler's position. People with cardiovascular or respiratory issues, okay, usually they lie in the Fowler's position, which I would say is a modification of the supine position, because this time around we've raised, okay, their back a bit upwards, okay. So that is one other thing that I want you to know, okay. Now, how do I know? If I lie prone, okay, then it means that my ventral aspect of my body is on the floor. That is pronation, okay. So if I'm prone, then what it means is that I am prone to infections, I'm prone to some pathogens around, okay, I'm prone to some kind of threats, okay, if my ventral portion is on the floor, and that is what we call pronation, okay. So you have to know this movement, which of course, so this way, if I'm using the forearm and the hand as an example, then this is the pronated, forearm and hand. Then if I do the opposite, then this is the supinated, forearm and hand. Okay, that is one thing that I want you to know. Okay, now having looked at this kind of movement, there's one thing that I want you to know, and that one is what we call some combination of terms. Now, last time I told you that if I have this, if I take a sagittal section running through the midline of the body, that is what we call the median plane, which otherwise you want to call it the mid-sagittal plane. Now, if you see that that is the mid-sagittal plane, then the good news is that anything which is getting closer to the midline of the body becomes medial. Okay, now look at my face right now on your screen. You see that my eye, okay, let's take for instance, this is my right eye and this is my right ear. Okay, considering the midline of the body, which one is very close to the midline of the body? I'm sure you answered that it's going to be, of course, this right eye that we are talking about, and therefore this right eye becomes medial to that of what you call the right ear. Okay, so this one is more medial while this one becomes lateral. You get it? So as a comparison, that I can say that the right eye is medial to the right ear. Similarly, I can see that the left ear, because it's further away from the midline of the body, I can say it is what? Lateral. Okay, lateral as far as the body is concerned, further away. Therefore, I can say that the right ear is lateral to, of course, the right ear. Okay, these are the things that I want you to, understand. Now, if I've seen that, now look at the position of my eye and look at the position of my ear. Okay, I mean, look at it now. My eye is in front, therefore it's anterior. Okay, and it's medial to this kind of, right here that I'm talking about. Therefore, I can see that this right eye of mine is anteromedial, in front. Okay, so you say anteromedial to, of course, my right ear. Okay, that is one thing that I want you to be aware of. Okay, similarly, now assuming I'm looking at what we call my zygomatic bone. Now there's a bone over here, this zygoma, this produces this projection over here. This is my right zygoma, my right zygomatic bone, which I can feel deep to the skin over here. Now if I'm comparing it, okay, to, of course, this right ear of mine. Now what do you see? You will realize that yes, both of them are in front, so both of them are anterior, no problem. But what do I see? What I see is that this one, which is over here, the right eye, is a bit medial compared to this right zygomatic bone, which is deep over here. Therefore, of course, simply we can say that this right eye is medial to the right zygomatic bone over here. However, again, if I'm comparing them, what I realize is that the right eye is a bit cranial, therefore I can use the word superior, and then this zygoma is a bit inferior, therefore, yes, it's a bit downwards, therefore I use the word inferior. And so I can say that the right eye over here is what we call it superomedial. Superomedial. You understand what we are saying? So superomedial is a bit upwards and it's closer to the midline of the body, while of course this zygomatic bone is a bit downwards, inferior, and it's also lateral, inferolateral to, of course, the right ear over here. So these are some combinations that you can use, okay, to explain some of these things. You understand what we are trying to say? So for instance, if I look at, this is my mental area, okay, that's my chin, my mental area. Now if I look at my mental area, okay, now assuming I lie, let's say supine, I lie supine, which means I'm downwards this way. Now what you realize is that if I'm comparing my nose, okay, to, of course, my chin, my mental area, then I can say something, that this nose, it protrudes a bit, the tip of the nose over here protrudes a bit anterior, more anterior compared to perhaps my chin over here. Therefore, yes, I can say that it's anterior. Okay, this one is a bit posterior, although yes, in real sense, they are all both projecting anteriorly. By relative terms, that's what we are talking about. That this, the tip of my nose protrudes, more anterior compared to that of my chin. Yes, again, my chin is a bit downwards, inferior, compared to that of the tip of my nose. Therefore, what can I say? I can say that the tip of my nose is, of course, superior, is a bit upwards, okay, and it's anterior. So antero-superior compared to that of my chin. Therefore, my chin over here is, posterior-inferior to, of course, the tip of my nose. These are relative terms. So sometimes we can combine some of these terms and, of course, get something out of it. Because there are so many structures in the body and we have to give a perfect description. So that whatever you are describing over here, yes, if another scientist comes around, if another anatomist comes around, the person will also have, fair idea of whatever you are saying. Okay, so that is a combination of directional movement. Now, there's one thing that I want you to know. There is something that we also describe. And of course, an English word. Sometimes we use the word proximal, we use the word distal. So proximity, okay, is also another point that we have to understand. We can describe structures based on their proximity to a point of reference. Whether they are very close to it and use the word proximal for that, or they are further away, distal from it. Okay, that is what we are doing. Now, if, for instance, now that one, it is based on a reference point that we are talking about. So for instance, if I say that the body, okay, this articular skeleton, I'm seeing this shoulder joint. This is a joint, shoulder joint. So my reference point over here is my shoulder joint over here. Now I see this bone. This bone over here is the humerus. Yes, the layperson will call the funny bone. Yes, the reason is that the word humerus, someone has a good sense of humor. Okay, the person is a bit funny. The utterances that the person makes, triggers that kind of fancy. in people. People will laugh. Please, you understand what they are saying? There's one nerve, okay, which runs behind this bone over here, okay, this medial epicondyle of the bone. We'll be explaining all these things for you, okay. If that nerve gets triggered, sometimes you put it somewhere and then it pains you, get that kind of funny feeling. That's why we call it funny bone, the layperson will call it, and then we also call it humerus, okay. So that's what we see. Now this humerus that we find over here, it is having it's a long bone. The first of all, it's a long bone. Now, whenever we have a long bone, most of the long bones, okay, they have this organization. They will have what we call proximal end of the bone. They will have a distal end of the bone, and they will have an intermediate body or the intermediate shaft. Okay, that is what we see for most of the long bones. Now, if the shoulder joint is my reference point, and then I will look at, for instance, this is the head at the proximal end of the bone. I have what we call this rounded head of the humerus. Yes, below that I'll have, anatomical neck and what have some tubercles also be present. But I'm not interested in so much already, so much of these. But what I want you to know is that, for instance, if I'm considering the head of the humerus and the body of the humerus, or if I even go downwards, I have epicondyles and what have you. If I'm comparing the body and then the head of the humerus, which one is very close to the reference point, by way of the shoulder? And your answer right over there will be the head of the humerus. And so whenever we say that, if I'm, for instance, having the head of the humerus, the body of the humerus, and I'm supposed to describe them based on proximity and the reference point is the shoulder joint, then I have to say that the head of the humerus is proximal to, of course, the body or the shaft of the humerus. Why? Because the shaft of the humerus is further away, away from the reference point over here, but the one which is very close to the reference point becomes the head of the humerus. Okay, so that is another thing which we look at, and that is the proximal and the distal terms. So these are antagonistic terms. So sometimes you have two structures, okay, and then you want to describe them. You want to say that one is very close to the reference point, one is further away from the reference point. Then one which is very close to the reference point becomes proximal to the one which is what further away from the reference point. That is what I want you to be aware of. Now there's one more thing that I want to tell you, and that is also describing structures based on how close they are to the skin. Now, if I have a structure and it is very close to the skin, the word we use is superficial. Simple. The word we use for that thing is superficial. Now, if I have a structure which is further away from the skin, okay, then if it is not superficial, then we use the word deep. So superficial. Of course, you learned about some of these kinds of frying. You know, we have superficial frying, we have deep frying. If you use very small oil, then that is what we call superficial frying, okay, or shallow frying. It is shallow, very close to the skin. But if you have more of it, then deep frying, if you go very deep, okay. So these are the terms that I want you to know. Now, if I'm having superficial and deep, then it means that if I have another structure, which is a tear structure, and I'm describing, then I can say that perhaps the tear structure is between the superficial structure and the deep structure. Then that structure becomes an intermediate structure. With respect to these three, structures we are talking about, one being superficial, one being deep. Then the third one, yes, perhaps is somewhere between the two, and therefore we use the word deep. So, for instance, if I have this, for instance, this is the breastbone. Now the breastbone is what the layman usually calls the sternum. So this is the sternum, which the layman will want to call the breastbone. These are the ribs, okay, which are called the costal bones, okay. And of course the bones over here, these are the costal cartilages. Okay, now it's a step-by-step thing that we are learning. Pretty soon you understand all these things and you really be able to explain all these things, okay, as if you are a guru in this area, okay. So take your time bit by bit and you understand these things. Now you can feel your own ribs over here. You can feel your own ribs. Now if you have your ribs over there, okay, now look at your ribs. Your ribs are there, very close to the skin. Now if I'm comparing your ribs to your lungs, okay, now for instance these are your lungs. Now I have some sections through the lungs, okay, these are your lungs. Now if you have your ribs and you have your lungs over there, just answer it for me. I'm taking an anterior view, looking at it, then my ribs, and then of course my lungs, which one will be deep and which one will be superficial? I am pretty sure you've answered that they are going to be the ribs. The ribs are going to be superficial. Why? Because they are just next to the skin. And anything which is further away, so for instance, the lungs are very deep and therefore they become deep to, of course, the ribs. Similarly, if I take, for instance, the sternum over here, very superficial, just beneath the skin, I'll find it over there. Again, over here, lying in what we call the middle mediastinum over here, this area, we have the heart well over here. We look at all these things. Now, if I have what we call the sternum and then the heart, then my question is, which one will be deep and which one will be superficial? Of course, the answer is going to be that I have the sternum to be, of course, superficial, and then deep to it will be the heart. It's as simple as that. Now, usually for intermediate, we don't talk about it so much, but just to give you an example, you know that the heart is covered by this kind of membrane, which will be coming to pretty soon, is, what we call pericardium, okay, fibrous pericardium, serous pericardium, whichever. Now, if I'm going anterior, taking an anterior view, then I will meet my sternum, then I will meet my pericardium before I go and meet the heart. Therefore, if I'm having these three structures, then I know that the sternum becomes superficial, the anterior portion of this pericardium becomes, of course, intermediate, and then the heart itself becomes deep. Okay, so these are the things that I want you to know. So that is also another aspect of the superficial and of course the deep. Now, let me get an example. Now, for instance, if this is someone's breast, this is just one of it. If I have the breast, okay, now you realize that the breast, if I'm having the breast, and I'm having, let's say, the heart, and I ask you to describe which one is going to be superficial, which one is going to be deep, I'm pretty sure you know that this breast, yes, it's in the superficial fascia, therefore it is going to be deep. It's going to be superficial. The heart is further, away, okay, from the skin, therefore it's going to be deep. Okay, so these are the things that I want you to be aware of. Okay, so that is, very good. Now, there are certain things that I want you to be aware of. Now, we look at something we call laterality. Now, anytime you look at lateral, then we say away from middle of the body. In other words, to the size of the body, to the size. Okay, that is the laterality thing we are talking about. Now, there are some structures, they are present, okay, solitary in the body. And whenever I say solitary, are single entities in the body. If they are there, then they become unilateral. To a particular side of the body, then they become unilateral. So, for instance, if I should give an example, okay, if you look at this guy over here, this one I'm pointing at with my thumb, okay, is your spleen. Now, the spleen is found in what we call the left, okay, upper quadrant. It is a solitary structure, a single structure that we are having in the body. Therefore, it's a unilateral structure. Similarly, I can take, my what do you call the liver? The liver, a very bulky organ, the heaviest internal organ next to the skin. Okay, the liver. Most of the bulk of the liver is in the right upper quadrant. Of course, some will project into the left. Okay, now what are we saying? It's just one side of the body that we are having it. It's a solitary organ. Therefore, it becomes a unilateral organ or structure. So these are the things. Apart from that, if you've seen unilateral structures, then it makes sense that you also have bilateral structures. That there are some structures, you find them on the left side of the body, you also find them on the right side of the body. Bilateral structures. And what are these bilateral structures we are talking about? For instance, now, again, if I look at the kidneys located in the retroperitoneal area of the abdominal cavity, okay, this is what we call the right kidney, and then I have the left kidney over here. Similarly, on top of the kidneys, I have suprarenal glands. This is the right suprarenal gland, and I have the left suprarenal gland over here. Again, if I look at the lungs, okay, one on the left, one on the right. Okay, if I look at my limbs, upper limb, of course, I have right, okay, left part of the upper limb, I have that of the right, my ears, my eyes. Okay, so these are what we call bilateral structures. They are on either side of the body? My breast. Okay, the testicles, they are on either side of the body, so they become bilateral structures. Now, more importantly, these unilateral bilateral structures that we are looking at, sometimes we can describe a structure with respect to another one. So for instance, I can describe the spleen and the kidneys. So for instance, I can say that the left kidney over here is on the same side as the spleen, because the spleen is also on the left side of the body. Therefore, the word we use for these structures is that they are ipsilateral. Ipsilateral. Because they are on the same side of the body, they become ipsilateral structures. Similarly, if I have this spleen and then, of course, the left lung, they are also ipsilateral structures. Okay, so these are the things that I want you to be aware of. However, if I take the spleen and then the right kidney or the right suprarenal gland, they become contralateral. Why? Because they are found on opposite sides of the body, contralateral structures. Okay, so please, as far as laterality is concerned, I want you to be aware of unilateral structures, bilateral structures, how we can also compare or describe structures by way of some being unilateral, some being ipsilateral, some being contralateral. Okay, that is what I want you to be aware of. Now, recently I had this problem, I encountered this problem, and then some students were doing something that I had to explain to them. Now, there is an important concept in human anatomy that I want you to be aware of. Okay, and that will take you to places. It will make you an outstanding person in whatever field that you will find yourself in future. And that is something I call hitchhiking. Hitchhiking in anatomy. Hitchhiking. Now, the word is hitchhiking. And whenever I say hitchhiking, I am interested in nerves. Nerves. Now, we have several nerves in the body, and they are doing, some of them are sensory, carrying sensations from some areas of the body. Some of them are sending, some commands. So some of them will have motor function. Will cause some glands to secrete, will cause some muscles to contract. So there are different kinds of nerves in the body. Now, let me give you an example. Now, sometimes you don't have a car, but you are going somewhere, and you want to join a particular car, to take you. You don't have it, but you are waiting for a car, but someone is going to your direction, and you want to join the person to go. Whether the person is familiar or not, but of course, the right way is to, join a car that you know the owner, very well. So you ask the person that, please, can you, drop me at the next place? Now, for instance, I have a very good, mentor. I have a very good, father. I have a very good friend. The head of the department of chemistry. And for instance, assuming he is going to Ejoso, he is driving to Ejoso, to go and do something over there. And I also want to go to Ejoso. But the only thing is that I don't have a car, but he is having a car. He is going to Ejoso. So what do I do? Then I have to join his car. Now, this is the example of hitchhiking that I'm going to explain to you. So I join his car. Now I go there to perform my own special duty. He also goes there and performs his own special duty. Now, does that mean that the duties that I went to perform, he did it for me? No. I just joined his car to reach my destination. That is what we call hitchhiking. Now, the same way in anatomy, in the human body, there are some nerves around. They fail to reach their destination on their own. So nature recognizes that, and therefore there are some nerve fibers, which will join some other nerves to send them to their destination. Typical example. Now, assuming I have my tank, assuming this is my tank. Now later you get to know that the tank will have whatever, anterior to tertius portion and whatever, posterior 1/3 portion, you see that. Now the anterior to tertius portion, the taste sensation is coming from one nerve. The taste sensation of the anterior to tertius is, let me talk about the general sensation. General sensation from the anterior to tertius of the tongue by way of pain, touch, okay, proprioception, what have you, any pain, any general sensation at all, will be carried by one nerve. And what nerve is that? That nerve, okay, is what we call the lingual nerve. Lingual nerve. So I'm talking about general sensation, okay, from the anterior to the tiers of the tongue, will be carried by what we call the lingual nerve. Now the lingual nerve, okay, is coming from the posterior division of what we call the mandibular nerve, which is a branch of the trigeminal nerve, the fifth cranial nerve. We are not going so much into that, but I'm just using it to explain something to you. This lingual nerve is going to carry general sensation from the anterior to tiers portion of the tongue. Now, there's one nerve, and this is the hitchhiking I'm trying to explain to you. There's one nerve which also wants to get to the anterior to tiers of the tongue. Now, this time around, it is not going there to carry general sensation. The purpose for going there, okay, is to carry taste. Now, taste is a special sensation, special. Just like hearing, vision or faction, like smelling, okay? These are special sensations. Now, this time around, this guy is going there so that I can carry special sensation from the anterior to tiers of the tongue by way of taste. Now, this nerve is actually called chorda tympani. The name is called chorda tympani. We'll explain all these things to you later. This is called chorda tympani. But for it to reach the anterior to tiers of the tongue and carry the taste sensation, it couldn't go on its own. Now, there's a branch of the facial nerve, the seventh cranial nerve. It couldn't go alone. Now, it realized that lingual nerve was going to the anterior to tiers of the tongue to carry general sensation. Then realized, why don't I join it? Because I can't go alone, then I join it. But at the end of the day, they will both go and reach the destination. Now, lingual nerve will go and perform its own function by carrying general sensation from anterior to tiers of the tongue. But this chorda tympani is going there to carry taste sensation from the anterior to tiers of the tongue. This is an example of hitchhiking of nerves in anatomy. Okay, so that is one thing that I want you to be aware of. But you don't go and say that because this one has joined it, it's the lingual nerve which is carrying, the taste sensation to know. Another example. Now, if I look at my tongue, there are some muscles. Okay, we have intrinsic muscles of the tongue, we have extrinsic muscles of the tongue. For instance, the intrinsic muscles of the tongue will help me change the shape. So sometimes the tongue becomes very slender, sometimes it becomes bulky and broad. Okay, changing the shape of the tongue. They are the intrinsic muscles. We will look at them later. Then we also have extrinsic muscles. Now, whenever we say something is intrinsic, it means by way of attachment, by way of origin and insertion. Okay, every muscle will have action, origin and insertion. I'll be explaining all these things for you. By way of course, origin and insertion, by way of the attachment, they are in the substance of the tongue itself. They are not attaching anywhere else. But if we say you are an extrinsic muscle, then apart from having one of your attachments, okay, in the tongue, for instance, you have another elsewhere. They are the extrinsic muscles. For instance, if you look at the tongue, they will have about 4 extrinsic muscles. Okay, the safety one, or being the largest one, fan-shaped muscle. Okay, being of course the genioglossus. We also have what we call the hyoglossus. We also have styloglossus, and then we also have palatoglossus muscle. Now, all these muscles, generally we say that whether it's extrinsic or intrinsic muscle of the tongue, we say that it is supplied by what we call the hypoglossal nerve, the 12th cranial nerve below the tongue, hypoglossal nerve. Is supposed to supply these muscles I'm talking about. But my friends, there's a catch. There's a discontinuity. One of the muscles is not supplied by hypoglossal nerve, and that is the palatoglossus muscle. It's rather supplied, usually in books, they will say it's supplied by vagus nerve. And that's a wrong concept that I want to explain using the same hitchhiking. So it's the same hitchhiking concept that we are talking about. So for instance, this, vagus, the reason why they are attributing to vagus nerve, and it's wrong, because we now understand the hitchhiking of nerves. That's the concept I want you to be aware of. So for instance, if there's a foramen, which we'll be looking at very soon, we call it jugular foramen. Okay, so assuming I have the jugular foramen, now there's one nerve coming out. This time around, that nerve is the vagus nerve. Vagus nerve, that's the 10th cranial nerve. But the cranial fibers of what you call accessory nerve, you see them, that's the 11th cranial nerve. It will have, cranial components, and it also have cervical component. The cranial component coming from what you call medulla oblongata, the cervical component coming from the cervical region of the spinal cord. They will join. But then anyway, I'm interested in the one which is the cranial component. Okay, now the cranial component, the spinal components usually will supply one muscle over here, the sternocleidomastoid, then to supply the trapezius muscle, okay, the one muscle over here. I'm interested in the cranial component. Why? Because this cranial component will also come out through the same jugular foramen from the cranial cavity, but this time around, instead of going alone, it will join this vagus nerve, and at the end of the day, it will go and supply these kind of pharyngeal muscles. So although this cranial accessory nerve, okay, the 11th cranial nerve is performing a lot, usually the credit is not given to it. No. Why do you do that? You give credit where credit is due. And that is why we don't say that no, it is supplied by what we call vagus nerve. No, if I don't agree to that, I rather say that it is supplied by what we call cranial accessory nerve via vagus nerve. And that is what usually some books will say vagal accessory complex. So sometimes later on you'll be reading and be hear of pharyngeal plexus. That is what we mean by that. Okay, and not so that is the hitchhiking concept that I want you to be aware of. Now there's one more thing that I want you to be aware of. There's something we call anatomical variations. Now of course, the way I look is different, far different from any of my siblings, far different from anyone else. Okay, perhaps I may have my look alike, we may be similar, but there will be some changes. Okay, that is what we mean by anatomical variation. Okay, so sometimes there are certain things we expect that this is the way it's supposed to happen, but there will be a change, and that is what we mean by the anatomical variations. For instance, later on in your study, you will get to know that the hand is over here, this is the aorta, this is the ascending aorta, then it arches. Okay, what do I mean by that? What I'm trying to say is that, assuming this my arch of aorta. Now this arch of aorta normally gives 3 branches. So I may have, let's say this is one branch of it, then there will be another branch, then there will be a 3rd branch. Normally, this is how it is. Now, this is a mirror image. So whichever belongs to your right, okay, it's actually the left part of the body. Now, there's 3 branches which will come out of it. And usually there's a mnemonic for it. We call it the BSC or the BCS branches. Now, if I'm moving from right to left, then what will happen is that this is why we call it brachiocephalic trunk. Then I'll have what we call left, because it's more toward the left side, so left common carotid artery. Then I also have left subclavian artery. Okay, you will see these things later. Because of anatomical variation, sometimes you don't see all these 3 like this. You just see 2 of these branches over there. You just see 2 of them. So you may just see brachiocephalic trunk, and you may just see what we call left subclavian artery. You don't see this left common carotid artery. Why? Because you'll be emerging from this brachiocephalic trunk. That is what we mean by anatomical variation. There are several of them in the body, and as we move on, we'll be talking about all these things, okay, in a while, in no time. Now, in anatomy, what are the standard colors